Good day. I am Hyla Kluyts. I'm a specialist anesthesiologist based in Ga near Pretoria in the Gauteng province in South Africa. Thank you very much for this opportunity to talk on the evidence on safety and quality of anesthesia practice in Africa in the session on anesthesia safety in low and middle income countries, a global perspective. In this talk, I will provide an overview of the evidence generated during the African Surgical Outcome Study, or ASOS projects, some of which are still to be published after the time of this recording. I've been involved in this work being done under the guidance of Bruce Pickard, as steering committee member and national lead for South Africa for the ASOS and ASOS 2 trial. I'm also the founder and director of Safe Surgery SA, the non-profit company that provided research support to these projects and administers the African Perioperative Research Group, or APOR. I would like to take this opportunity to acknowledge the dedication of the thousands of colleagues that participated in these projects and the tremendous leadership of Bruce Pickard, and specifically in this talk, the passion and commitment of Fitsum Kifte from Ethiopia to the APOR cause. So we all understand that quality and safety of healthcare are hampered by a lack of resources, and those of us working in low and middle income countries understand the impact the inability to provide safe, effective, people-centered care in a timely, equitable, integrated and efficient manner have, not only on the populations we serve, but also on the personal and professional well-being and resilience of clinicians and healthcare workers. The barriers to clinical research in Africa were reported in this paper by researchers at the University of Cape Town. And the study was done after completion of the African Surgical Outcome Study, and ASOS investigators were asked to participate. So facilitators of research included establishing a research culture, the use of simple data collection tools, and good ASOS team interaction. And most participants were interested in future research, 93.8%. And that is how the APOC network was created. We will be briefly looking at some of the results of the ASOS projects using the Denebedian approach to measuring quality of healthcare, that is structure, process and outcomes indicators, with safety as a component of quality. And key points to be discussed are that data from surgical outcome studies in Africa have provided the direction for future research, that large collaborative studies are powerful tools to not only generate evidence but also assist in advocacy efforts, and that future research should be conducted for Africa by African clinicians. So ASOS at the time was the most comprehensive assessment of surgical workforce density and patient outcomes. And the data set also included observations on use of the WHO Safe Surgery checklist, intraoperative anesthetic complications, provider training and experience. And then also data captured by each hospital lead investigator included data on the level of hospital, whether it was university affiliated, private or public, the population served, and the resources available at the facility. It was a 7-day prospective observational cohort study of adult patients undergoing surgery in these 25 countries in Africa. One of the first outcomes that one can gather from this is the perioperative mortality. And considering perioperative mortality rate as a crude indicator of quality of care, one should consider the principal findings of ASOS, which were that despite being younger and healthier, patients in Africa were twice as likely to die after surgery when compared to the global average. And in the maternal and neonatal outcome sub-study, it showed that maternal mortality after a cesarean section in Africa is 50 times higher than that of high-income countries. And neonatal mortality is double the global average. With regards to resources and infrastructure, a sub-analysis of ASOS data regarding post-operative outcomes following procedural sedation by non-physicians and physicians in Africa is currently being considered for publication. And hospital context or health environment resources are likely to play a significant role in outcomes also after procedural sedation. Little data were collected in ASOS on district hospitals, and the numbers here that shows that only 8.3% of cases were done at first level hospitals or district hospitals. With regards to processes, the ASOS risk calculator, which is predicts composite outcome of severe complications and death, were developed and then subsequently used in the ASOS 2 trial. And of relevance is that the use of a risk prediction tool and preoperative risk stratification is an indication of quality of care, but also that predictive modeling can be used to risk adjust perioperative mortality rate as recommended. So the ASOS 2 trial, death after surgery in Africa is largely driven by post-operative complications such as sepsis and bleeding in the hospital ward environment. And the trial was conducted to assess whether enhanced post-operative surveillance reduces mortality in adult African surgical patients. And at the time of the recording, the paper has been submitted or accepted for publication in the Lancet Global Health. So we saw that anesthetic complications together with obstetric hemorrhage were significantly associated with a composite outcome of severe complications and death in the obstetric sub-study of ASOS. And in the full cohort, 27% of patients with anesthetic complications experienced the composite outcome. The use of the WHO Safe Surgery Checklist. This checklist was used in 57.1% of cases in ASOS, but unlike this study that we referred to here, that we reference here, in ASOS, no association with reduced mortality has yet been demonstrated. These top 10 research priorities for Africa were developed during a DELPHI consensus study and published last year, and includes a number of relevant studies for safety and quality of perioperative practice in Africa. So what are the data we need? We need definitely more information on the context or setting where we work, and that includes facility resources and the referral and support that could explain poor post-operative outcome, particularly at first-level hospitals. We need to establish a way to routinely capture electronic data by clinicians. And lastly, we need to include quality indicators as part of a standardized core perioperative clinical data set, particularly indicators on the safety and efficiency of care. And current projects and future plans include the fact that we have developed a minimum perioperative data set for Africa in a DELPHI consensus study. and will implement this in an African registry to track risk-adjusted perioperative mortality rate at facility level. And the ASOS 3 trial to reduce maternal mortality after caesarean section is being planned.